When we first see a patient with hyponatremia, we have to first determine if it is a non-hypotonic hyponatremia versus a hypotonic hyponatremia. In order to do that, we have to compare between osmolality and osmolarity. Osmolality with an L is a laboratory measured level, while osmolarity is calculated using this formula. We will allow a ±10 difference between the two values before we will call it a significant difference. If the lab measured osmolality is actually more than the calculated osmolarity, this may be due to translocational hyponatremia or a pseudo-hyponatremia. If the osmolality and the osmolarity is matched, then we might suspect that it may be due to a dilutional hyponatremia in which the ADH is suppressed, or a condition with an ADH that is elevated. We shall first discuss translocational and pseudo-hyponatremia. In translocational hyponatremia, it is a subset previously considered to be under pseudo-hyponatremia. This occurs when there is a gain of impermeable solutes which cannot easily cross the cell membrane. Examples include glucose and mannitol. When there is a gain of the impermeable solutes, this results in a rise in plasma osmolality within the extracellular fluid compartment. When the blood is taken and left standing in a blood tube, water from the intracellular red blood cell fluid would shift out into the extracellular compartment, diluting the sodium. Therefore, this is not a real hyponatremia, and it is also not due to a lab error. We can calculate or estimate the amount of hyponatremia contributed by certain solutes such as glucose. For every 3.3 millimoles per liter rise in glucose, the sodium can be expected to drop by 1 millimole per liter. Pseudo-hyponatremia occurs if the lab still uses the dilution-based method. In this method, a standard volume of diluents is actually added prior to the measurement of serum sodium. Normally, serum sodium is distributed across both the aqueous or the water phase as well as the non-aqueous phase or the solid phase. In this solid phase, it includes substances such as proteins or lipids. After a standard volume of diluent is added, in order to lower the concentration of sodium, measurements are taken for the aqueous phase of the blood sample. In conditions which result in an increased fraction of solid phase particles, such as multiple myeloma with an increase in the protein phases, or hyperlipidemia with a lot of lipid in this phase, when a standard volume of diluent is added, this results in a lower than expected serum sodium measured in the lab. Most labs nowadays do a direct reading with no diluent added. This removes the error of pseudo-hyponatremia. If we have excluded a pseudo-hyponatremia or translocational hyponatremia, the next step is to work up a hypotonic hyponatremia, and the investigations are centered to determine if ADH is actually suppressed or active. The urine osmolality is a very useful parameter to look at. We already know in the previous lecture that the urine osmolality, or the concentration of the urine, is directly proportional to the amount of ADH activity. If the urine is very dilute, with less than 100 milliosmoles per liter, we can presume that there is no ADH activity, or the ADH effect is absent. This may be due to psychogenic polydipsia, low solute intake, such as beer potomania or in tea and toast diet syndrome, a reset osmostat syndrome, or in advanced renal failure, where the ADH is unable to exert the effect on the kidneys. How does beer drinkers' potomania occur? Beer provides calories through alcohol, and the high amount of calories will actually sustain the drinker, who will not feel hungry and will not feel the urge to look for food. Alcohol is, however, metabolized to give only water with very minimal solutes. Therefore, if a person drinks beer without any other food intake, assuming 200 milliosmoles per day in 5 liters of beer, with a maximum dilute urine a normal person can make at 60 milliosmoles per liter, the maximum amount of urine volume is 200 divided by 60, which is 3.3 liters per day. This is further aggravated by a reduction in ADH secretion in heavy alcohol drinkers. The prevention is, of course, to have some form of food intake with salt and protein, such as peanuts. If the urine osmolality is more than 100 milliosmoles per liter, we can assume that there is actually an ADH effect. We next have to determine if this ADH excretion is actually appropriate or inappropriate. In order to do that, we look at the urine sodium concentration. If the kidneys are also trying to retain sodium such that there is a low urine concentration of less than 20 millimoles per liter, we may presume that the ADH secretion is appropriate and look for any causes of volume or water loss, such as from the GI tract or from the skin, or even from third space loss, such as in nephrotic syndrome or in RAS activation. However, if the urine sodium is high, more than 40 millimoles per liter, we have to consider the possibility of a renal loss, and we have to consider if it is SIADH, or the syndrome of inappropriate antidiuretic hormone secretion. What is the definition of SIADH? The definition has been set since 1967 by Barter and Schwartz. In that, the patient will have hyponatremia with hypoosmolality, with a continued renal excretion of sodium, and the urine is less than maximally dilute. This must be in the absence of clinical evidence of volume depletion, such as normal skin turgor and a normal blood pressure. And this should also be diagnosed in the absence of other causes of hyponatremia, such as in pituitary insufficiency, hypothyroidism, adrenal insufficiency or RAS blockers, cardiac failure, liver disease, renal disease with salt wasting, as well as any drugs such as diuretics that impair renal water excretion. The correction of hyponatremia is, of course, by fluid restriction. After establishing the diagnosis of SIADH, it is very important to go on to establish what is the underlying cause. This includes intrathoracic lesions, including malignancies in the lung, or other lung conditions, such as infections, acute respiratory failure, or even positive pressure ventilation. It also could be due to central nervous system or intracranial issues, such as mass lesions, stroke, and other conditions. Many drugs have been known to cause a syndrome of inappropriate antidiuretic hormone excretion, such as desmopressin. Finally, other conditions that result in stress to the patient, such as pain and post-operative state, or even severe nausea, can result in an SIADH.